Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator for today, Carol Fancott, Director at the Canadian Foundation for Healthcare Improvement. Please go ahead.
Hello everyone, and welcome to today's informational webinar on the Bridge to Home Collaborative Information Call. We're pleased to offer this call with simultaneous interpretation today. If you wish to view today's slides in French or listen to the French audio, please let us know in the chat box and our producers will help you out with that. We also invite you to participate in the chat box discussions throughout the webinar in either official language, and we will ensure that the key comments are read aloud for our translators or interpreted by Isabel, who is here with us in the studio. So let me begin with a few introductions. I'm Carol Fancott, and I am sitting here in the CFHI offices with Christine Micah, Angela Morin. So Christine Micah is our Senior Improvement Lead. Angela Morin is our Patient Partner. And we also have key support from our webinar folks, Kelly and Sheena, and we also have Isabel with us. And we are coming to you from the CFHI offices, which are on the unceded territory of the Algonquin Nation. We also have joining with us today Gail McKean, who is a patient partner with Imagine Citizens out in Alberta. And we're also joined by Shoshana Hahn-Goldberg, who's with Open Lab at UHN in Toronto. So for today, there are going to be a lot of slides. So I'm just giving you a warning in advance that these will all be available to you after the webinar so that you can review them. But we are going to go through them quite quickly, and we want to ensure that we're leaving lots of time at the end for your questions. But we're going to speak about the topic of transitions, and I think importantly, certainly hearing about the patient and family experience of transitions in care, and Gail is going to be leading that conversation. We're going to be talking about the components of this new collaborative, the Bridge to Home, of which there are 4 components to the Care Transitions Bundle. We're also going to talk about the collaborative itself. You know, why would you want to apply to the collaborative? What are the structures and supports that will be available to you? And certainly provide you with the information that you need to be able to apply to this collaborative if you're interested. And so to begin, I'm going to start with a very brief overview of CFHI and what we do through these collaboratives, and then we'll be handing it off to Gail to really share with us, you know, why this is such an important area and the experience of transitions. And then we're really going to get into the components of this new collaborative, the Bridge to Home. We'll hear from Shoshana, who will speak to us about the patient-oriented discharge summary, which is a key feature of part of the Care Transitions Bundle, and then Christine and Angela will be speaking about partnership with patients and then the different parts of the application. And so to begin about CFHI, many of you may have heard about our organization in the past or worked with us in previous collaboratives, but we are a federally funded not-for-profit organization, national healthcare organization that is really dedicated to accelerating healthcare improvements. And we do this by identifying proven innovations and really look to spread and scale them across Canada. We are really focused on the triple aim, or I guess more recently the quadruple aim, where all of the work that we do really looks to focus on this accelerating healthcare improvement by improving the patient and family experience of care, improving the health of populations, and adding value for money. And also importantly, paired with the patient and family experience is really the provider experience of providing the care together with patients and families. You can see on the slide shown the many different areas that we are involved in. We have a number of collaborative programs that are currently running and that we will be launching in the future in these priority areas. And the way that we do this is by really developing these collaboratives where we are able to work shoulder to shoulder with all of you, with teams and healthcare organizations across Canada, where we look to build leadership and capacity in quality improvement methodology, in change management. And a key feature of all of our collaboratives is really enabling patient, family, and community engagement. At the Foundation, the work that we do related to patient and citizen engagement is really thinking about active participation in a range of activities and really tapping into the expertise by experience that patients and families bring to the work that we do. And we really look to foster a partnership model. And this is the definition that we use at CFHI for patient engagement, which comes from Tambuser and colleagues from Health Expectations in 2011. The framework that we use at CFHI comes from Kristen Carman and colleagues, again from Health Affairs, and many of you may be familiar with this. And the area or the level of engagement that CFHI has worked in the past number of years is really that red band in thinking about what does it mean to partner with patients and families in meaningful ways in organizational design and governance, and particularly in quality improvement initiatives. You will see that CFHI has actively been involved in a number of collaboratives since 2010, where we have supported 51 teams across Canada since 2010 to work with families and patients in quality improvement initiatives. And that we really, again, focus on co-design as much as possible and really valuing the new insights that patients and families can bring in working together with providers and really feeling that in the end it leads to better results for everyone rather than just working on their own. And so the next slide that we'll show is just the number of collaboratives that we've done since 2010 with PEP. With these collaboratives, the kinds of supports that we've been able to offer in terms of seed funding and the teams that have engaged with us over the last number of years. And so this latest collaborative, the Bridge to Home Spread Collaborative, is really focusing on the idea of transitions. And we're using a definition that was brought from Jeff's and colleagues in thinking about transitions as a set of actions designed to ensure the coordination and continuation of healthcare as patients transfer between different locations or between levels of care within the same clinical setting. I will say the Bridge to Home Spread Collaborative is very much positioned in looking at the transition specifically from institutionalized care, so from hospital settings, back into home or the community, and thinking about how is it that we are able to bridge that continuum from one care team within an institutional setting to the next care team that may be out in community. And so I'd like to welcome Gail McKean now from Imagine Citizens in Alberta to share with us her experience and her family's experience with transitions to really help to position us for the importance of doing work in this area. Thank you, Gail.
Oh, hi. Good morning, everybody. It's Gail. I'm sitting here in Calgary on a beautiful sunny day, and I only have 7 minutes, so I better get going. So as Carol said, I'm from an organization, or with an organization called Imagine Citizens Collaborating for Health, which is a sort of grassroots group here in Alberta that sprung up to patient citizen-led, and we really want to work in partnership with the health system here in Alberta to develop a better healthcare system, honestly. So I have 2 short stories to share, one a positive experience with transitions and one negative. And I think I got tapped to do this by Alex Harrison, who's been working closely with CFHI and is part of Imagine, because I've had well, a lot of hospital experiences. So, and a lot of then that means a lot of transitions from hospital to home. My son was born, Sam, was born with complex medical problems. You can see the picture on the slide really is a picture of Sam in bed, really now as a young adult behind a bunch of pumps. So his need to go into hospital has continued into his adult life, often for surgeries. It's a bit of a long story, but I had to reach back when I was talking to Christine Micah about thinking about a positive transition experience, and I think in hindsight we had many positive experiences in the child health system, and I couldn't really think of any in the adult health system, which is not really a very positive. I'm sure there are some, and I know friends who've had them in the adult system, but I haven't had any. So I reached back because I think the positive experiences, I think a wonderful example of what transition can look like, and I think it applies across any kind of age group or system. So when Sam was about 3 years old, he had bacterial endocarditis, which was an infection in his heart. We were informed after he had been admitted to the Children's Hospital here in Calgary that he had to be on antibiotics, IV antibiotics for 6 weeks. At that time, I also had a 5-year-old daughter at home, and the thought of yet another hospital stay, and be a long one, was something that was going to be really challenging for our family. We lived across the city from the hospital, and I always felt torn between being with Sam or being with Ellen, and we could bring Ellen, but that had all kinds of challenges as well. So I just asked whether it might be possible, whether they had ever done IV antibiotics at home, and much to my delight, they were just trying to set up a program at the Children's Hospital to be able to do that. So we were able to take Sam home on IV antibiotics. And I think when I was reflecting on what made that such a positive experience was that there was really good teaching in the hospital. So me, because I was going to be the one doing it, and my husband was involved as well, but he was kind of the backup guy. We got trained to administer the IV antibiotics at home. We felt we got to practice in hospital, in a fake kind of way doing it, and felt really comfortable. We were also set up with lots of support. So we got written instructions obviously about how to do this. Home care was going to be coming in at least initially daily to check up. We had a number to call, home care, 24 hours a day, where we could get in touch with somebody. Our community pediatrician, who knew Sam really well and our family really well, was there, as was the cardiology clinic at the Children's Hospital. So we felt really well supported. When we took Sam home, it was really uneventful. We didn't have any significant negative events happen. I mean, we also, I guess another thing I should add, we had been written down the things to look out for. And of course, in this case, it was primarily looking out for whether his line was staying intact, or whether he was losing the line, or whether he was developing any kind of infection around the line. So, we knew what to look out for. And then if we were at all concerned, I said we could phone home care and they could come and take a look. But one time he did lose his line. I think it was about halfway through by the time we got home, we think we just had about a month left of IV antibiotics, and he almost lost the line. So but we knew. So I called the home care number, and they actually said, well, just take him to the ER. But the good thing was they had set it up so someone met us in the emergency room, and they changed the line, and it was really went really smoothly. And of course, it meant that we could be at home with Sam, and it was a lot better than being in the hospital for a month. So I think it was a really good example of a transition from care in the hospital to care at home, with feeling really well supported. And I won't spend long on this, but a more recent negative experience. Just over a year ago now, Sam, who's now, well, at that time was 25, had to be admitted to hospital due to he was having some severe abdominal pain that they hadn't quite been able to support out, and it kind of reached a climax. I wasn't even in town at the time. I was away. He was admitted to the hospital with severe abdominal pain, and he also had pneumonia. He had picked up a cold, and I think the pain had prevented him from breathing deeply, etc. Anyway, he was in for about a week, and initially they were going to do some emergency surgery, but then decided that it was too complex for the access team or the surgery team on call, and wanted to refer him to a specialist surgeon. So they decided to discharge him home. They discharged him home on a weekend. I wasn't at the hospital when they made the decision, and anyway, and Sam desperately wanted to get home at this point. So the problem was there wasn't really a very clear discharge plan other than call the surgeon on Monday and make an appointment to see him. Sam did have a prescription for inhalers and steroids for the pneumonia problem, but he had, they had not given him any pain medication. Of course, in the hospital, he'd been on IV, hydromorph, etc., was still on that, so wasn't sure what he was going to be doing at home. In the end, after talking to Sam on the phone while he was in the hospital, they ended up paging the resident, and he got discharged with Tylenol 3s. Long story short, it took 3 weeks to get in to see the surgeon. During that time, the pain management part was really challenging, and the care in the community was compromised again because Sam's family physician had just retired. So we could go back to see someone in that practice, but he had no one who knew him. And we all know, I think, that young men with pain challenges trying to ask for stronger medications is hard. So he ended up just basically hanging on with the Tylenol 3s. But it wasn't ideal. And then it ended up that 3 weeks after that, indeed, he did have to come back to the ER. That was the discharge instruction if something happened. Go back to the emergency room. So he did. And he ended up requiring emergency surgery to, it was a complex. It ended up he'd had a marginal ulcer that had ruptured. And anyway, good thing is he survived. He's still around, but not the most ideal transition of care into the community and then back into the hospital. So I think that's it. That's my positive and negative experiences with hospital transitions, which I don't think are unique.
Thanks, Gail. It's Christine, and you know, it's great to hear sort of, I don't want to call it the highlights, but you know, at the beginning hearing that there are good things that can happen, and especially in pediatric facilities, the notion of patient and family-centered care has emerged and I think evolved, and we take a lot of inspiration from there. And I hope never that the good news is someone survives, and as you quoted, like we can do better than that. So appreciate, you know, both candid sides of the coin, and recognizing that continuity and the value of being a partner in care as well, and a caregiver's experience. So thank you. And what we're hearing in Gail's story, both some of the challenges and in her experience, is she's certainly not alone, and this has been well documented in the literature. Although transitions in some ways is a difficult part of healthcare, which through Gail's story we often hear about people experiencing the system wanting to know whose responsibility is it to ensure that these transitions are safe and care is consistent across the transition points, as patients and families are often the only common thread between hospital and home. And the research evidence does support the experiences described by Gail, in that transitions are often a period of stress for patients and caregivers. Translations are correlated to less than ideal outcomes, including repeat visits to emergency rooms and readmissions. And we know from research from CIHI that many readmissions are actually preventable. And finally, patients have experienced inconsistencies in care when coordination is lacking, and this often leads to confusion about what actually comes next. And adding to these communication gaps, there are other gaps, such as health literacy levels. We think about language barriers that exist in our bilingual country, where there are many languages spoken. Retaining information during significant times of stress can be an impediment to that continuity. And caregivers aren't always involved in discharge planning. And finally, a lack of confidence in being able to assume care upon discharge is often an assumption made as patients and families leave the hospital. So just advancing to the next slide. And from the evidence, Burke and colleagues have created this bridge model that we like and were inspired by. And the bridge model highlights some of the components of an ideal transition from hospital back to community. And the model is anchored at one end by care teams within institutions, and at the other are care teams within the community. And this bridge requires collaboration between sectors. It requires engaged patients and caregivers throughout the process. And this model uses a multi-pronged approach to address these 10 domains. And what we know from the evidence is that addressing multiple interventions is more likely to improve care. And so within the context of this collaborative, we've sought out innovations that touch on some of these domains. And certainly we are limited within the scope of the collaborative and what we can accomplish together in 17 months. We do anticipate addressing and touching on a number of these domains to guide how we are going to improve transitions. And so I'd like to spend a little bit of time introducing the format. What is a collaborative, and how is it that we will come together and work together? And so we use the word collaborative as a noun to describe the educational opportunity to bring together these interprofessional teams to address healthcare issues like transitions through a team-based and a quality improvement approach. And through the collaborative, we support capacity building, both for quality improvement, in engaging patients in quality improvement work. We provide education and coaching as well as advisory services. And this is done both virtually and in person with a dedicated group of individuals interested in quality improvement on this common topic of transitions. And our goals within this particular spread collaborative really are to improve the patient as well as the caregiver experience of transition from hospital to home or to community care. We'd like to improve the confidence of patients and caregivers to manage their care as they make their way through this transition. Carol's talked about the quadruple aim, and a big part of that is improving the provider experience of care. We believe that there's correlations between avoidable hospital readmissions that are worth examining. And finally, key to our work in our portfolio is enhancing the ability of teams to partner with patients and with caregivers on improving transitions. We want patients and caregivers to be an integral part of the work and an integral part of the quality improvement teams working on improving transitions. And so the collaborative itself runs for 17 months in total, and prior to the official beginning of the collaborative, we are here on this webinar providing information and hopefully answering questions that you might have. We'd invite teams to submit expressions of interest between now and August 15th. There will be a merit review that will take place, and accepted teams will be notified the week of September 10th. Following acceptance, there's an orientation webinar that will take place the first week of October, and a face-to-face meeting taking place in early November. Following the workshop, there'll be virtual webinars that take place approximately every 6 weeks that are all 1 hour and devoted to educational content on quality improvement, partnerships with patients, measurement and evaluation, and learning about the specific innovations and how others have implemented them. Teams will be required to submit progress reports along the way, and together we'll create a measurement plan to understand the difference both with partnering with patients and caregivers in quality improvement, as well as impacts related to improving transitions. And finally, there will be follow-up after the official end of the collaborative, where we'll reach back out and hear where you are in terms of your sustainability and spread. There's many benefits to joining a pan-Canadian collaborative, and we hope you will consider joining. For this collaborative, each improvement team or network is eligible for up to $40,000 in seed funding. In addition, you'll be connected to a network of like-minded improvement teams, including access to patient advisors and other team members across the country working on similar initiatives. You'll gain access to experienced faculty and coaches to deliver educational content and provide coaching, and who will provide coaching to help navigate barriers along the way. This collaborative offers educational sessions, as I've mentioned, via webinar and in person for you and your team on topics such as patient engagement, measurement, spread, and sustainability. And finally, all accepted teams will have access to online learning platform where you'll be able to engage in discussions with other improvement teams, gain access to and share resources and tools, as well as a place to submit reports. And so throughout the course of the initiative, accepted teams will be partnering with patients and families to introduce a suite of 4 interventions to improve care transitions. And so I will outline these 4 transitions, and then I will pass things over to Shoshana to talk a little bit more about PODS. So PODS is really the first intervention I'll briefly mention. And this is an innovation that was designed with patients for patients as a tool and a process to communicate information that patients and caregivers need to know in a way that can be easily understood. And Shoshana on the line has been leading this work at Open Lab, and she will share specific details on this intervention. The second intervention or innovation is the teach-back method. So integral to PODS and at other education points during patient care, teach-back is a way for providers to ensure they're communicating in a way that patients understand. And we know that using teach-back improves patient knowledge of their condition, adherence to treatment plans, as well as self-efficacy in managing their care. And as part of the patient-oriented bundle, improvement teams will proactively take steps to welcome families as partners in care. Angela once made the bold and all too true claim that you can't partner with patients and families if the doors are locked. Patient advisors will be integral in identifying how they are being welcomed as part of the circle of care and what barriers persist. Finally, to help strengthen the continuity of care, improvement teams are invited to come up with a way to follow up with patients and caregivers once they leave the hospital. This is where the home and community organizations can work together with patients and families to develop solutions such as post-discharge follow-up calls, home visits, or other interventions. And certainly we recognize that adaptation is key to spreading and scaling innovation, and teams are encouraged to customize these 4 innovations to meet their local context. So I would, at this time, like to pass things over to Shoshana at Open Lab, who will tell us more about PODS and share a couple of case studies.
Hi, everyone. This is Shoshana from Open Lab. And I'm going, just as Christine said, just tell you a little bit about PODS and give some case studies. I just wanted to briefly mention Open Lab is a design, research, and innovation center located at University Health Network in Toronto, but our work spans outside of the hospital walls into the health system, and this up here on the screen is a picture of our manifesto. A lot of our work really, we work with users, and patients, of course, are users, and really use design techniques to work with them to create solutions. So POD stands for Patient-Oriented Discharge Summary, and it began as a co-design initiative with patients and families, and really from the very beginning, even the idea of which problem to tackle came through a patient experience mapping exercise in November 2013. Following that, we created a team that had patients and families on it, and also made special effort to connect with patients and families that are generally harder to reach for co-design initiatives, such as those with limited health literacy, language barriers, mental health conditions, to really, so some of the innovative ways that we used to work with these patients included using a cultural probe kit. So that included a journal and a disposable camera that we gave to patients who were screened to have very limited health literacy, to take home and document their time at home right after discharge to figure out what would they have benefited from being given at the hospital. So this on the slide is the template that we created with the patients and families, and this template really represents two of the 3 categories of guidelines that really make up a PODS. So what makes up a PODS is the content, the design, and the process. So the content, 5 main pieces of content that patients told us is important to them to know at discharge. Information about their medications, how they might feel, and what to do. So that includes things that are normal. So, for example, if it's normal for them to be in pain for another week, they would like to know that, as well as worrisome symptoms and when to go to the emergency department. Changes to my routine, which would be things like when to resume normal activities, as well as any changes to diet and exercise, follow-up appointments with phone numbers and whether or not they were booked, and then where to go for more information, again, with phone numbers. For design, you'll notice there's room for the patients to take notes, which was very important to them, as well as really clear headings, separating the sections, large font, use of plain language directed to the patient, that kind of thing, and then process changes really are covered by other initiatives in this in the 4 buckets in the collaborative. So from there, from the design, we then did what we called an early adopter pilot, and 8 hospitals in the Toronto area implemented pods in at least one patient group, and we were able to collect some pre-post data through that implementation. And this slide just shows the difference in the change pre and post of PODS implementation, of how well patients understood various sections of their discharge summary. So overall, there was about a 10% improvement. And each hospital, really, what they do is they take the guidelines and the template and they adapt it to make it work for their own patient population and their own discharge processes. In addition to the pre-post of patient understanding, we also looked at the provider experience and found that it did not add to their workload and, in fact, made things more consistent and made them more confident in relaying discharge instructions. So right now, starting in 2017, we were recipients of an ARTIC grant, which is a grant to spread innovations across Ontario, put out by HQO and CAHO. And this map shows the hospitals that are part of this ongoing community of practice that are implementing PODS in their hospitals across Ontario. So now I'm going to just give a few examples of how different hospitals have used PODS. And some of the key things to note, as I mentioned, each hospital really makes it their own. Some of the things that might differ from hospital to hospital are when the PODS is given. Is it part of the regular discharge summary process that goes to the family doctor as well? Is it its own separate process? Is it given during a meeting or a teaching session? Is it something that started from admission or not? Also, who is responsible for filling it out and giving it to the patient? That also varies from hospital to hospital. It could be an interprofessional team, a single responsible provider, or some have even given blank forms to the patient and family for them to fill out over the course of their stay. How it's delivered, some have it built into the electronic health record. It might pull some information automatically based on a patient's diagnosis. It might be available through a patient portal. There are many hospitals using paper forms to give to patients to take home, and some using a mobile application as a platform for delivering their PODS. And then what is included in the PODS, whether it's all blank and filled out individualized, or is it that the patients with certain diagnoses have some pre-filled standard content that's always there? So the first case study I'm just going to quickly run through. One of the hospitals involved in our community of practice right now is CAMH, and this is just an image of their original discharge summary. And they were able, from April 2017 they went live across their whole hospital in November 2017 with PODS built into their electronic system. And this just shows a side-by-side of what their form looks like compared to the template. And some changes that I just wanted to point out are in the language. So in the original template, it says, I came in because I have at the top, and in the CAMH template, it says, I came in because I was feeling. And that change in language is something that makes more sense for their patient population. And also, if you look at some of the sections, So they're a little bit different. Instead of changes to my routine and where to go for more information, at the bottom of their pods is my goals and community help to reach them and my supports after discharge. Another example I wanted to run through was at TRI, the Toronto Rehab Institute, with their stroke patients. So their original pre-implementation process involved a team-based assessment with discharge teaching preparation throughout the rehab stay, a care conference at some point before the patient is discharged, and then on the day of discharge, the patient was given a discharge binder and a discussion. So this was their process. They took from June 2017 through December to create their PODS tool. Some of the key steps involved in their process were forming a working group, assessing the needs and gaps, and developing a tool and process that really made sense to fill those needs and gaps that they found. And their new process is very similar, except they've added a discharge teaching meeting. So 3 to 4 days before discharge, they use PODS to structure a meeting to use TeachBack and see how much information the patient understands that they need to know at discharge. And this is just an image of their TeachBack guide that they use to facilitate that meeting with the patient. Another example from Toronto Rehab, which is very similar to the stroke experience, but what they do at their TeachBack PODS discharge meeting is they fill out the PODS together with the patient in the patient's own words, and then the patient takes that home. And then I just wanted to show 2 more quick examples. These are both from the early adopter pilot. On the left, you'll see a patient, the green patient-oriented discharge summary. It's from Sick Kids, and it was mostly blank with some information pre-filled. Something that they added was all the contact information as well as a small to-do list of things they often found families were forgetting to do before they left. And this was printed on cardstock and given to the patients at admission. And any time a nurse came into their room over the course of their stay to do anything related to discharge teaching, they just reminded the family to please pull out their PODS so they could use it to take notes while they did this teaching. And that's actually a 2-sided, you only see one side of that document. And then on the other side from St. Joe's Health Center in Toronto, this was one created specific to I think it was for COPD, and so they pre-filled all the how I might feel and what to do section, and they used colors to really highlight what are the expected symptoms, what's worrisome, and what they should do, and what is an emergency. So that brings me to the end of my slides.
Thanks so much, Shoshana. It's great to see all of the work that's being done in Ontario and that you've really been leading, and the adaptations that people in their context are really able to see and use based on their patient populations. And so we've been talking a lot about patients, we've heard from patients, and I now want to turn it over to our patient partner to talk a little bit about the opportunity that exists to form partnerships with patients in this particular initiative.
Great. Thanks, Christine. So as we've heard from Christine and Shoshana and from Gail and Sam's experience, there are lots of opportunities for learning and improvement that patients and caregivers are experiencing in the gaps between organizations and providers. And teams in this collaborative will identify opportunities for patient and caregiver involvement at key times to strengthen the continuity of care and in the implementation of PODS. So clearly this collaborative is focused on partnership and transitions with patients and caregivers as receivers and partners in care. But to reiterate, the collaborative is also very much about co-designing the transition bundle with patients and families in the design of the transition bundle and as members of the project team. The role of patient advisors on the team is to take teams from the doing to and the doing for to the doing with. for them to help identify the opportunities for patient and caregiver partnerships in the project, as well as an implementation of the transition bundle, to share their experience with transitions, to identify measures of success, and to bring their perspective to the conversation. So what this might look like for the patient advisors on the team. The expectation within this collaborative is that the patient advisors will not play a token role, but will be a full team member. Patient or caregiver advisors will offer the perspective of the patient and caregiver experience throughout the quality improvement initiative. They may serve as a liaison between the initiative and other patients and caregivers or councils within the organization, as well as support broader engagement practices throughout the initiative. Patient advisors can challenge the status quo, question, support, and motivate. They can ensure that the patient perspective is being considered in the design of the bundle and that the things that matter to patients are being considered in defining success. Based on my experience as a patient advisor, coach, and faculty member in other CFHI collaboratives, I can confidently say that once patients and caregivers start working as a member of the team, you, the patient advisor, will begin to see many ways to contribute. You bring a different lens that will bring a critical perspective to the work. You can provide advice and guidance in planning the project and reviewing documents. You can help develop and deliver education and communication tools. You could find opportunities to engage additional patients in the work to broaden the patient and caregiver input. You could share your experience with staff and leaders, telling your story to reinforce the importance of this work. You will help to ground the work, make it real, and keep it on purpose to create a better patient and family experience in transitions of care. Your presence on the team will change the conversation. Do not be afraid to have your voice heard. The key to successful engagement of patients on the team is to actually include the patients and caregivers, ideally more than one of them, on the team. That may seem obvious, but sometimes the patient ends up feeling like an outside member who is only invited in to participate when the rest of the team thinks it's appropriate. To be a full team member, the patient partner should be included in choosing meeting times the same way all other members are included. You, as the patient partner, may not need to be at all meetings, but you should be part of the conversation determining where you can most meaningfully contribute. Remember, this is about doing with. It is important for the patient partner to be included as a team member from the beginning, as early as possible, like now. When patient advisors need opportunities to be heard, but they also need to see how their input is influencing the work. How is what I am contributing being incorporated into the work? This is not just about patients sharing their feedback on what is important to the rest of the team, but sharing what is important to them as a patient or family member. It's about others learning from the patient and caregiver's lived experience to make the project better. Therefore, it is important to ensure all members understand the role of the patient representative on the team and in the project. The CFHI team recognizes that for some advisors, this will be a new way of being engaged. And for many organizations, this may be a new way of engaging patients and caregivers. And we recognize that not everyone is comfortable doing this. And so, throughout the collaborative, there will be resources, coaching, and education to support meaningful engagement. We are providing links to resources such as the Patient Engagement Resource Hub at the end of this webinar that includes tips on how to successfully engage patients and families in building quality improvement initiatives that were developed by both patients and providers. I encourage you to check them out early in this process. Co-designing improvements with patients and families leads to new insights and better results than providers and leaders working on their own. It is this partnership, the sharing of ideas and expertise that will help your team create a successful and sustainable bridge to home.
So thanks, Angela, and we're lucky to have you as our patient partner to help us think about how we're engaging and how we're supporting others to engage. We do want to leave a lot of time for questions during our question and answer period, so I will briefly provide an overview of how to apply to the collaborative. We've just included the link to the specific web page where all of the resources live. This will also be where the recording and the PowerPoint slides will be as well. So first is really to assemble your improvement team, and Angela's grounded us in the notion that we should be engaging patients early. So there are 4 required team members when you're assembling your improvement team, and we would ask you to consider how others might be involved as well, in particular those who will be directly affected by these changes. And what we talk about in our prospectus document, as well as the application or expression of commitment, is the notion of applying as a network. And we're really looking for organizations, for example, hospitals partnering with community organizations to improve transitions together. And in particular, that follow-up innovation will require that hospitals are working with community organizations. So please do consider who in your network you might wish to partner with in terms of a network application. The expression of commitment, which I just referenced, is available on this website. This is the formal application process, and we've listed a number of sections within this expression of commitment. You are most welcome to contact us. My name and email are included. It's Christine, both on the website as well as in the PowerPoint. So there's a few sections to fill out. We'd like to know what the current state of your transitions is now, your readiness to engage patients and caregivers in quality improvement, and who's on your team. There is a conflict of interest form that is a formality we'll ask you to fill out as part of your application. And lastly, the application is submitted to me. So I'm Christine Micah. My email address is there, as well as on your expression of commitment. So please do submit all applications to me. And those are your 4 easy-ish steps. Looking ahead, the applications are due on August 15th, so please have them in to me by then, and teams will be notified the week of September 10th. October 3rd is sort of the first official webinar session in the collaborative. We'll provide an orientation, what it is we're going to be learning about, who all is in the collaborative. There is a requirement for teams to submit and complete a memorandum of understanding, which is just the general principles of how we're going to agree to work together within the context of these 17 months. Everything will be posted on our website. Again, the link will be there, and the recordings will be up in approximately 2 business days. So look for those to come up, and they will be, the full recordings are available. Lots of resources on our website in different places. Please do look at them. And lots of references, as we certainly are not blazing the trail, but rather building on what others have done in the research and people's experiences. We did want to leave time for questions, and we have approximately 15 minutes to go. So if you haven't already, please do add your questions, and we will go and review these and see what people's reactions are, what people are asking, and hopefully this helps to inform you in terms of your seeing if this is a fit. So the first question was offered by Della, and she's asking, by transitioning to home, do you only mean to one's own residence, or are you considering also the transition from a hospital to a transitional home, such as a long-term care facility or a group home facility? And so our answer is yes, we're willing to consider any of these. We're defining home as wherever the patient is transitioning to next in community. So certainly if you are from a long-term care facility or a group home, we would welcome that application as a network with a hospital or someone providing institutional care. And I'll just scroll down to see, I think there is at least one more question. So there's a question that I'm seeing from Gail. Love the PODS presentation. Thank you, Shoshana. Is PODS a one-way sharing of information from the hospital to the patient, or does it include a discussion about what might be possible for the patient or families to do at home? For example, can they forward medication? Do they have a way to getting 2 follow-up appointments? So I guess to be sure, we're extending the co-design concept to the individual pods at the bedside. So Shoshana, can I pass that over to you to answer how patients and caregivers are involved at the bedside related to pods?
Sure. Thanks for the question. So really, in the ideal situation, PODS is given to a patient through a discussion, through teach back, where patients and families are asked those kind of questions of what kind of help they need at home, what are they not able to follow up on, and they're given opportunity to ask questions to their healthcare providers through that discussion, whether it be at a meeting or just a one-on-one teaching session. So that's the ideal. That's the ideal situation of how pods should be given.
Sure, and thanks, Shoshana. And I know there's another one from Becky at Prairie Mountain Health, and she's asking, is there an estimate of how many hours of project management would be involved? And I think it's a tricky question to answer, and maybe, Carol, did you have sort of a first, related to the types of projects? And Shoshana, I'll push it back to you to just give your insight on what's been the level of involvement over, I know you had done this in an accelerated way over a few months, but if you had a comment first, Carol, and then back to Shoshana.
Yeah, Becky, that's a great question, and it's making me think back to some of our other collaboratives and how did people use up the budgets that were allotted. I would certainly say for the most part in the budgets, it did tend to go to human resource hours, and how you allot those will be dependent on the type of initiative that is being implemented. And so I think, this one is hard to say, and I would suggest thinking to other initiatives that you're doing within your organization, and are there ways to gauge what in relative to the implementation of a care transitions bundle, what you would be estimating in relation to other initiatives that are going on. I would also welcome the advice from Shoshana, because right now they currently have a number of hospitals and organizations in the field that are implementing pods. And so, Shoshana, you might be able to shed a little bit more light specific to the work that's going on in Ontario.
Sure. So I can't say for sure how much project management time is really needed for each hospital, but a number that's kind of been thrown out by groups that are implementing pods is like somewhere between 0.3 and 0.6 FTE for about 6 months to get it going. And then once it's going, it depends really what the plan is for how it's being implemented. Is it implemented across the hospital all at once, or is it implemented in one group and then there's still some work needed to implement it again in the next group and to spread it to the next group? But that's some numbers that we've seen. In terms of like hospitals that are implementing in, let's say, a single group of patients, and they're able to do it in 3 to 6 months, and then they don't really need any more ongoing project management because they're able to integrate it into the processes of care.
I hope I'm seeing Becky answering. Thanks very much. This is helpful information I can share with our CEO. That is, I think important when making your decisions and bringing that forward. Another question, Shoshana, asking about, is there any testing in transitioning home from the emergency department? So I'm not sure if any of the early adopters or those in the ARTIP program are working on transitions from emergency to home.
Yeah, so right now we have one hospital that's already started working on transitioning home from the emergency department. So there's some learnings and different challenges from that setting as there is from an inpatient setting. Most of the work has been done either from inpatient or from rehab. But in some of the hospitals that are in the community practice now are also starting to work on that emergency department transition.
Thanks, Shoshana. It's Carol here. And what I would like to add is, absolutely this is a key transition point that is often talked about both by patients, families, and caregivers, but also in the literature of how difficult that transition often is. So definitely welcome teams that are thinking about that particular transition. I'm going to move to the next question, which is from Sherry and Allison, who have both asked how many teams will be chosen. So in our prospectus, we had initially said, and in the budget that we had proposed within CFHI, that we would be able to support 12 teams moving forward. I would like to say, though, that we are flexible, and certainly if we have an overwhelming response to this call, we will certainly be looking to increase those numbers as needed. And it's also dependent on the amount of money that people are asking for in their budgets. Not everybody asks for the full amount, and so that often gives us some wiggle room as well to include more teams than we had initially thought. We're going to move to the question from Shannon, and what criteria are you using to select the successful applications?
Yeah, sure. So it's Christine, and I'll just move back to a little bit earlier. I glossed over it fairly quickly, but at least it will provide an overview of what we're asking for. So all of the merit review will be done from the expressions of commitment that are submitted by the organizations. We have been explicit in welcoming networks, so those who are willing to enter into partnerships with community organizations and hospitals in particular. But also you'll see there's room for what is the current state like? Have you implemented any of the 4 innovations that we would like to? And if you have, that's okay. But we'd like to know how being part of a collaborative might help your efforts in improving transitions from hospital to home. We have been explicit about understanding organizations' readiness to engage patients and caregivers in quality improvement. So again, it doesn't mean that you're not excluded if you haven't done it before, but we want to see that you've put some thought into the potential roles. And Angela talked a lot about the structures that are helpful and necessary to meaningfully engage patients from the beginning. So it can be sort of the minute things like when are your meeting times and how early are people engaged, but we'd like to see that consideration as you begin to onboard patients on your team. And we do explicitly ask about the patient advisor as one of the named team members, so we would certainly be looking for that as well. I hope that provides you a bit of an overview. If you haven't checked out the expression of commitment, please do so. And if you have questions in addition to what I've described, either just chat them in the chat box or get in touch with me. It's Christine.
It's Carol here, and if I can add, from a CFHI perspective, what we're looking for are teams that we can feel confident that are going to be able to implement the Care Transitions Bundle within their organizations, and that they've demonstrated how it is aligned with their strategic priorities, that they have a strong team in place, and they're certainly ready and willing to partner with patients and caregivers within their work. So those are the kinds of things that we are looking for, and certainly, as Christine had pointed out, I would assume that most hospitals or most organizations are doing work in this area or have certainly given it some thought. And so if you can show how you're building on this work, how you're looking to spread it across or within your organizations, it's those kinds of things that I think we really want to be assured.
So we probably have time for approximately one more. We do have a quick evaluation at the end, but what I can commit to is we will take all the questions in the chat and we will answer them in a PDF document that will be posted in the same location as where we're posting the video. And that is at the website that I have provided once already, and I'll just post it again. And we will commit to having that in English and French, so do not despair if we don't get to your question. And I just have time for one more. I'm correct in that we would receive a package of materials or documents that can be adapted to our context, i.e. not reinventing the wheel. So yes, we know that adaptation is key to any innovation sticking and spreading and scaling it within any context. So we welcome adaptations, and I think Shoshana's done a really nice example of showing how PODS has been adapted. But likewise, there are with the other innovations, the idea of welcoming families as partners in care. If it's not teach back, what other sort of educational strategy or communication strategy are you using? We're very open to the adaptation if it's in line with sort of the philosophy and principles of partnering with patients in that particular area. So I'm sorry we have not had time to get to all of the questions, but would like to thank you sincerely for your participation on the call today. And I hope that you will consider joining us in submitting an application. So again, for any additional questions, please don't hesitate to reach out in English or in French to me, Christine Micah. And as you do leave the webinar, please take a few moments to let us know about your experience today by answering the following questions. And the first question is, did the session give you the information needed to make a decision to apply? So yes or no. And after participating in this webinar, do you intend to apply to the collaborative? Yes or no. And if you do have any other comments or suggestions, please go ahead and type in your answers here. Again, within a couple of business days, we will have everything posted on our website. In the meantime, please don't hesitate to give me a call or send me an email. And this will conclude our webinar today. Thank you again on behalf of all of the speakers for joining us. Thanks very much.
This concludes today's call. Thank you for your participation. You may now disconnect.